My name is Yaniv Ribon. I am honored to serve on the board of directors for the Epilepsy Foundation of Michigan, where I'm privileged to wear a number of hats and contribute in many ways. But more than anything, I am just proud to be a member of our community. The community that together we have built and we cultivate together in our great state of Michigan. And if you are here from outside of Michigan or online from outside of Michigan, welcome. We are elated to have you. I am grateful to share that this next session is sponsored by CS Mott Children's Hospital, part of the University of Michigan Health System, otherwise known as Michigan Medicine. And so in this session, Dr. Chloe Hill, adult epileptologist at Michigan Medicine, and Dr. Kerri Neville, who is a pediatric epileptologist at CS Mott Children's Hospital, will talk with us about treatment options for drug-resistant epilepsy. They will talk with us for about 50 minutes, and then I'm going to come back up and facilitate some live question and answer. And so I hope you take some time to think through some questions and conjure the courage to ask them. So we'll do it that way. With that, Dr. Hill, Dr. Neville, come on up.
Hi, everyone. I'm Chloe. I've never been to this conference before, and I have to say it's incredibly moving to experience this community. Thank you so much for inviting me to talk today. I'm thrilled to be here, and I'm particularly excited to talk to you about this topic with my awesome colleague, Kerri Neville. So we'll get started. This is a big topic. We'll do it the best we can do with it, and we look forward to questions at the end. All right, so this is basically what we're going to talk through. We're going to talk a little bit about what drug-resistant epilepsy is, how we think about it as clinicians, and then go through options of treatment. So I'm going to go through a very academic definition of epilepsy. Obviously, if I asked you what epilepsy is, you would give me a more colorful, real-life definition, but I think it's important to level set about what epilepsy is academically, and then what drug-resistant epilepsy is. So the way we think about this is basically reaching a threshold where someone's had enough seizures or enough reason to have risk of more seizures that they need an anti-seizure medication or treatment. And that's how we ground this definition of epilepsy. Sort of quickly, we might say at least 2 unprovoked seizures, but there's a couple other elements that we consider, does someone need treatment? And about 1% to 2% of the United States population has epilepsy. How well do our anti-seizure medications work? Well, fortunately, they work pretty well overall. So this is showing data from 2 studies, one in 2000, which was kind of a landmark study in our field that helped us define how to think about response to therapy, and then a more recent one. And these show similar things. About half of people with seizures achieve seizure freedom with the first medication, so that's pretty good odds. Another significant portion achieve seizure freedom with their second medication, and then subsequently to that, you can add additional medications that may help you. In general, about 2/3 of patients or people with epilepsy have achieved seizure freedom, so that's a fairly good amount. But there's also people who can't achieve seizure freedom with medications alone, and that's what we're going to talk about today. One thing I just want to take a moment on this slide is, although there's bigger numbers with the first and second medication, every time we try a new medication, there is a chance that it's going to be the one that's going to make the difference. So as we talk about these other ways to treat seizures in addition to medications, they're not instead of medications. We think about these things in parallel. But what I want to draw your attention to is the chance of achieving seizure freedom with these medications drops significantly, and that's why we consider other ways of treating seizures, which may have slightly more risk or be slightly more invasive, and we're going to talk about those now. So drug-resistant epilepsy, we talked about epilepsy. That's showing that you've had multiple seizures or you are at risk of having more seizures. Drug-resistant epilepsy is defined by whether or not seizures were controlled with medication. And so typically we use a threshold of failure of adequate trials of 2 tolerated, appropriately chosen and used anti-epileptic drugs. So that means it was the right drug for those type of seizures. It was a real trial. All the things that you might think, tried to didn't work to get seizure freedom, or seizure control, and so that reaches the threshold of drug-resistant epilepsy. And now we're going to talk about the other options in addition to medication, which we still consider in parallel to treat drug-resistant epilepsy. I want to set up the context a little bit, which I really don't have to tell the people in this room, but I'm going to do it anyways to build into the rest of this discussion. So the burden of uncontrolled seizures is substantial. There's a lot of evidence that I can quote to you, and people in this room may have lived experience about it decreasing quality of life. It increases, uncontrolled seizures increase disability and unemployment. There's real consequential driving restrictions and transportation issues. There are associated psychiatric comorbidities such as depression and anxiety. Social stigma is still, unfortunately, a much bigger problem than it should be. And there's an elevated risk of death, to be really frank about this, which I think is important when we consider risk-benefit calculations. There is an elevated risk of death with uncontrolled seizures, and we talk about sudden unexplained death in epilepsy often in this context. It can reach up to 1% in annual risk. And there's other accidental injuries and deaths that are associated with this. So this is a real burden, and we weigh this against what can be done. So this is leading me into the case for epilepsy surgery. Epilepsy surgery is not new. It's been done for over 100 years. We've learned a lot along the way. It's done better than it was in 1886, fortunately. But I want to talk to you a little bit about what we know about epilepsy surgery. So one of the really important studies looking at this, one of our highest levels of evidence, which is a randomized controlled trial, was performed in 2001. So we're well into this body of evidence about how effective and how safe it is. This was a study of people with temporal lobe epilepsy, which is the most common type of focal epilepsy in adults. As a side note, we have certain seizures that target focal epilepsy, we have certain procedures that target focal epilepsy. We have certain procedures that target generalized epilepsy. So all seizure types should be included in this discussion, but what I'm talking about right now in this trial is a focal epilepsy. Comparing patients who underwent surgery versus medicines alone at 1-year follow-up. And, the point of this, what this study demonstrated, is that seizure freedom was much greater in the surgical group, close to 60% versus the medical-only group, close to 10%. And quality of life was also improved in the surgical group, and complications were not that common. And the one death was actually in the medical arm. This shows the same data visually, if you're a visual person, which I am. On the left, you have the medical group. The blue bars are no seizures, and on the right, you have the surgical group. The blue bars are no seizures, and you can see this dramatic difference with epilepsy surgery. And this really established how effective and how safe this procedure can be. This is another chart to show you. We've studied this now over time. Obviously, 2001 was a long time ago. This is actually still another old article, but I like this table. We continue to study it. There's more recent evidence. But this one describes also how it can be helpful with seizures in different locations. And the likelihood of seizure freedom can differ by where your seizures are coming from. It's also hugely individualized. But I wanted to show you that we use it across different types of epilepsies as well. Okay, so the seizure outcomes after surgery, and then we'll get into the procedure, but I just kind of want to tell you about why we might do these procedures. The most important one probably is to treat seizures, and we care a lot about achieving seizure freedom. This is a common way that we score seizure outcomes after epilepsy surgery, the Engel Epilepsy Surgery Outcome Scale. Ideally, people will be in class 1, free of disabling seizures, but you can also hugely improve quality of life and safety and the other things that I talked about just by improving disabling seizures. So we have a classification scheme for all of these goals. There are also many important non-seizure outcomes after surgery. Survival has been shown to be improved with a lower death rate of close to 9 of 1,000 person years in the surgical group versus the medical group in this study. Quality of life is improved. Employment depends on which study you see. Driving is improved. And I want to make a point that in the short term, we don't rapidly taper medications, but in the long run, that's also a possible outcome of achieving seizure control. With surgery, you may be able to get off many, if not all, medications. Cognitive outcomes are improved. There was a fantastic session just before this on cognitive outcomes, so I won't spend a long time on it. But we do also see improved outcomes of some types of cognition after surgery, particularly compared to non-surgery, which can not achieving the seizure control that can come with surgery and having ongoing seizures that can harm cognition. Complications of surgery. Now, this is brain surgery, so I don't want to undersell that it's an invasive procedure, although we have levels of invasiveness. But the major medical complications and major neurological complications are relatively low for a major brain surgery. So because of all this evidence, about 20 years ago, there was a strong recommendation that there's benefit of, this was specific to that older evidence about temporal lobe resection, but there's evidence that surgery is beneficial as compared to medication. And I'm quoting now, for patients who are compromised with such seizures, referral to an epilepsy surgery center should be strongly considered. Okay, so now we're going to dive into how we know what type of surgery and if surgery is right for someone. So I want to preface this, which I think is obvious, but I want to say it out loud. All of this is extremely individualized to a person, as it should be. It's an operation on a person's brain, but I'm going to give you the overarching ideas of how we think about this and how we assess for brain surgery. So there's two critical pieces to assessing if surgery is right for someone. I think if people get to the point of where surgery could be right, it definitely makes sense to look into it, understanding that you'll gain more data and figure out if it's right for you or not. You don't have to know at the start if it's right for you. The point is to go through the exploration and figure out if it's right for you. Okay, so we need to know where the seizures are coming from, obviously. And the second is we need to know if that is a part of the brain that can be removed to treat seizures safely. So there's a very famous epilepsy surgery really gone wrong from 75 years ago, from the 1950s, before we know what we know today. A famous patient called HM who had bilateral surgeries on the parts of his brain critical to memory. His seizures were somewhat improved, but he could not form new long-term memories, which was devastating. Not an acceptable outcome to anyone. So as we're assessing, do we know with great certainty where the seizures are coming from, we're also assessing, do we know with great certainty that that's a piece of the brain that's safe to operate on? And that's why it's quite involved to understand if someone would be a good candidate for surgery and what surgery that should be. So this looks complicated. It can be complicated. It's highly individualized. And the only reason I show this is because it's a very careful and individualized process. This is not something that's jumped into, but we also really know very well how to assess this. And there's a lot of support along the way to get through this process for people for whom it makes sense. Okay, so we obviously need to see seizures. We use electrical data, electrical assessment to figure out where the seizures are coming from. Obviously, a seizure is abnormal electricity of the brain. We have to capture and understand that electricity. This is showing, for people who get excited about EEG, a left temporal seizure. We have to understand the structure of the brain. We want to understand, is there something unique to a certain part of the brain that makes it capable of generating seizures? We put all this information together. This is showing, I don't know if I have a pointer. Oh yeah, okay. This is showing a part of the brain. Maybe it stands out to you in the left temporal region that looks a little bit bright. Maybe there's a scar there, and that can hint to us there's something abnormal about that part of the brain. We do neuropsychological testing. This is a functional assessment of how the brain thinks. So if you're particularly good at language function, it's less likely that your seizures are coming from that part of your brain that processes language, because that part's working very well. If you struggle more with math, it might be a hint that seizures are coming from that part of your brain because that part of your brain's not working so well. We put all this information together. It goes on, but I'm going to keep going. So we test people's speech, how well they do with word recognition and speech skills. We do other ways to study the structure of the brain. So we have several clever ways to understand this. I showed you an MRI, which is an image of the structure. We look at how the brain metabolizes energy, because that can hint that one part of the brain is metabolizing energy differently, and that might be where your seizures are coming from. We do a SPECT scan, which injects a radio tracer at the onset of a seizure that can highlight where that seizure starts. And there's other ways to study the electrical assessment. We might do magnetoencephalography, which is using magnets to assess the electrical dipole within the brain. This is a very cool study that takes a while to explain. I'll try to do it really briefly. We'll do a WADA study to see if we removed a certain part of the brain from one side, can people still function? Does their memory still work? And we can actually do a experiment, like sham version of that, by putting half the brain to sleep and seeing if people can still function normally. And we will do that to collect that safety data to make sure that the seizure surgery that we're planning would be well tolerated. This is a very cool test called AWADA. And then if we need further information, often we'll plan a surgery where, in addition to the first electrical data that I showed you, which is from electrodes on the head, we may put electrodes in the brain to find with absolute certainty where the seizures are coming from and to test that it's a safe place to operate on. And then sometimes we'll actually try to record information about how the brain functions by giving electrical stimulation inside the brain. So very thorough, really multifaceted assessment to get to the bottom of this. So we have all this information. We went through all the stuff. I didn't even talk about semiology. Obviously, we care what the seizure looks like. That helps us tell where the seizures are coming from. And then we put all this data together and we think, what is the best surgery for a person? To date, our best seizure freedom outcomes are with surgeries where we can remove that tiny piece of tissue where the seizure is starting. We call those resective surgeries. If we know exactly where the seizures are coming from, they're coming from one part of the brain, and we know with great confidence that it's safe to remove that one little part of the brain, we prefer that because the seizure outcomes are better. We call that resective surgery. However, often that's not a good option. The seizures are coming from multiple parts of the brain. The seizures are coming from all over the brain in a generalized epilepsy, or we know where the seizures are coming from, but it's not safe to resect that part of the brain, to cut out that part of the brain because that's critical to language. Then we have a lot of other ways to treat seizures through neuromodulation, which is this amazing field that's blown up in the last decade that Kerri's going to tell us about. So we have lots of options. It's not like you get to the end of this and you're out of options, and that's the beauty of all the advancements that have been made in our fields. So to very quickly go through these resective options, and then I'll turn it over to Kerri. So a very common surgery that is performed for temporal lobe epilepsy, in fact, the one that I introduced the topic with in that randomized controlled trial from 2001, is an anterior temporal lobectomy, where the front part of that temporal lobe is removed. Sometimes we can be even more precise with how much tissue is removed in a surgery. We don't have to get such a broad area because of where the seizures are coming from. And then a small part of that, instead of, this whole tip of the temporal lobe, a small part of tissue can be removed. This is called a selective amygdalo-hippocampectomy. Sometimes it's not in the temporal lobe, often it's not in the temporal lobe, but there's a part of the brain that looks abnormal to us, either electrically or structurally, and we can just remove that part of abnormal tissue. That's called a focal resection. Sometimes, for a variety of reasons, a person may not be a good candidate for a large craniotomy where part of the skull is opened. It's a big surgery. And we can offer another type of treatment, which is a laser ablation. We can zap it with a laser. And it's basically a catheter that inserts to the brain without a large craniotomy and causes a little bit of the tissue to be ablated or zapped in layman's terms that can treat seizures. Oops, sorry. Sometimes it's a large part of the brain that needs to be removed to treat seizures, and it can be a rather large surgery called a hemispherectomy. There's also a procedure called a corpus callosotomy, which we don't as frequently use in adults. Can I ask you to give us a minute on this? Or you can come up. So Kerri's going to talk to you about this because it's more commonly used in peds.
So I think one of the things that the goal of our talk today was to briefly touch on the wide range of options, and knowing all the options to treat epilepsy can be empowering. And so we focused so far on a resective option, but there are so many options for all different types of epilepsies. So corpus callosotomy is classically using a disconnection surgery. So the corpus callosum are the white matter tracts, the kind of superhighway of the brain that connects the two hemispheres. And for a certain type of seizure called an atonic seizure, it can be particularly helpful to disconnect that tract. Because an atonic seizure is a sudden drop seizure, and it's that really, really quick propagation to the motor centers of the brain that can cause that drop seizure. And if you interrupt that pathway with a corpus callosotomy, disconnecting those fibers, you can stop those drop seizures, is one of the main goals of this surgery. And so one of the shifts in epilepsy surgery has been not using only seizure freedom as a marker of success or improvement, but quality of life as well. And if you can control even specifically a sudden drop atonic seizure, but the person might have other seizure types, that can be huge in terms of mobility, functional status, and quality of life. And we'll go on to talk about other options as well.
That was perfect. Thank you, Kerri. Okay, actually, I got lost in my slides. That's the end of my part. The rest is going to be Kerri.
So we are both very excited about this topic, and we both, I think, tend to talk fast because we are very excited, and we had a lot of information to cover. This is another kind of switch in how we are thinking about epilepsy and epilepsy surgery. So one is the outcome of surgery doesn't necessarily have to be complete seizure freedom, though that's always the first hypothesis that we're working towards when we meet a patient. And then two, we were talking at our table a little bit about, the why someone has epilepsy and how that why can still be so elusive for so many people. But I think of neuromodulation as a little bit of a paradigm shift into the what. What is the seizure? What is that person's epilepsy? And that's something we're understanding a little bit better. And if we think about seizures and epilepsy as more of a network problem, when you don't have a single structural problem like Dr. Hill was going through, but rather a broader network. What are ways we can target and modulate then that network to be able to improve seizures and improve quality of life, even if a single resective focus or a single curative option seems less likely? And so we have more options than ever before, which is exciting, but we still have so much to learn. And so right now, as of now, there are 3 different neuromodulation devices that we can consider for a person who has refractory epilepsy, who medications alone maybe helped but were not sufficient, who maybe went through the epilepsy surgery evaluation or we knew early on maybe would not be a good candidate for a resective surgery. But even at the end of that long pathway, or even if we know early on it might not be the right option, we have other tools and other treatment options. So the 3 devices or neuromodulation options are vagus nerve stimulator, VNS, DBS, deep brain stimulation, or RNS, responsive stimulation. And this picture was already shown today. It's a nice way to look at those 3 devices and where they're placed, and we'll go into each one in more detail. How they work are very similar in a lot of ways, but there are a lot of nuances and differences too. And so again, the idea is that we are modulating a network. And so what we mean by that is the brain is composed of billions of neurons, right? Those are the cells of the brain, are the neurons. And in seizures and in epilepsy, a portion of these neurons are acting in an electrical way that's different. And if we can, even just from a region of the brain, figure out why the network is acting differently and modulate that network, that can be really helpful. And so that's the general approach of all 3 of these neuromodulation devices. Where you're modulating that network depends on which device you're talking about. So this was, I thought, just a nice picture showing that you're working on different areas of the brain for each of these devices. I also liked this picture. I hadn't really conceptualized it quite this way until I saw it. So looking at the baseline, someone who has risk for seizures, that risk changes maybe throughout the days or months or years. And we think of the seizure threshold. If you stack up enough risks, enough factors, your threshold of having a seizure gets lower, your probability of having a seizure gets higher, you might have your breakthrough seizures, and then you go through periods where things are relatively quiet, and then your threshold gets passed and you are at more risk of having more seizures. Responsive nerve stimulation, the idea behind it is that you're spending more time in the lower risk area, the lower probability of having a seizure. So it recognizes and responds to that individual seizure network, and with the long-term goal of spending more time in the lower probability zone than the higher probability zone of having a seizure. Continuous stimulation are what the DBS and VNS are doing. It's giving continuous stimulation, traditionally at least. And the idea there is that you still have these fluctuations, but you shifted the whole curve down into the lower likelihood area of seizures. So you're reducing someone's seizure burden, you're making seizures less likely, and hopefully improving quality of life, even if it doesn't mean complete seizure freedom. So a little bit more about each device and what they look like. The vagus nerve stimulator we have the most experience with. A lot of people in the room might have heard of this device or be familiar with this device. This is where the device is actually placed, the generator, the battery, if you will, in the chest wall, and then the leads are up, tunneled into the vagus nerve in the neck. And so it's actually done by a neurosurgeon. It is an epilepsy surgery, but it's not a brain surgery in the traditional sense. It's all outside the brain. So it's modulating the vagus nerve, and going back, we do think that that modulates networks in deeper structures of the brain. It's the green areas highlighted here in this picture. There is a magnet that comes with this that the patient themselves has, that they can swipe the device to intervene on a seizure when it happens, give an extra stimulation, extra dose at the onset of a seizure, which can sometimes be helpful. And then these are the tools that the provider would have to help program the device and set exactly what those stimulation treatments are. So that's the wand that gets held over the device and then downloads information onto the tablet where we can actually see and then program new settings. So I guess I should have had a disclosure slide. I have no disclosures, no financial implications for any of these devices. I'm trying to present an unbiased view of all three devices, though I am a pediatric neurologist, so I have used these devices off-label as well. But to go over the approved indications for each device, the vagus nerve stimulator is approved for children and adults 4 years of age and older, so it's the only device that is FDA approved in the pediatric population. Again, it's the one we have the most experience with. It was approved back in 1997, and we think of it as a good treatment for both focal and generalized epilepsies that are not amenable to other surgery, like a resective surgery. Practical considerations is that battery life. So the battery life for a VNS lasts between 4 and 8 years. It's a pretty wide range because it depends on how often the device is going off and how much battery that utilizes. So the stimulation, so we're talking about delivering extra current or extra electrical activity into an abnormal electrical network is the idea, again, behind all these devices. How the VNS does that is it's usually set, or is set, for continuous on for 30 seconds, off for 5 minutes is the kind of starting parameter or dose, if you will, and then that can be changed and modified over time. So that's the duty cycle. How much of the day are you seeing that stimulation? So 30 seconds of stimulation, off for 5 minutes, and so that's how much time during the day or the duty cycle that you are seeing that therapy, that treatment. There are some, the newer model of a VNS stimulator can detect heart rate with the idea that heart rate increases and increases quickly at the start of a seizure. And so it can give an extra dose of stimulation when it detects that heart rate change with the idea that kind of indirectly responding to potentially a seizure or that abnormal electrical activity by giving an extra dose of this current into that network. And then the patient has the power to swipe their own magnet too. If they see a seizure coming on or a provider or someone care provider sees a seizure coming on, they can swipe the magnet as well, which can be powerful. When we talk about, the efficacy of these devices, we heard about the efficacy of medications and surgical options. I use kind of a very broad approach to describing the efficacy of these and say up to 2/3 of people get a 50% or more reduction in their seizures. And in the literature, it depends, on what group of patients you're talking about, what time point you're talking about, how long after surgery or the device placement are you talking about. So it really ranges, but I think that's a fair kind of broad, up to 2/3 of people get a 50% or more reduction in their seizure burden. And we'll see that's roughly true for all these devices, like I said, with some variability. It is still surgery, even though it's not brain surgery. The complications for all these devices, whenever you're talking about an external medical device, would include infection and a bleeding risk. Though again, since it's all outside the brain, then some of those risks are lower. You have a bleed, at the incision site, it's much different than having a bleed in the brain. Some of the unique potential side effects for VNS is because you're stimulating that nerve. So other things that nerve does is some of the kind of laryngeal muscles and vocal cords, and so you might have some hoarseness or a cough. Usually those things improve over time, and you can kind of adjust settings, kind of like going up slowly on a medication to avoid side effects. There are ways we can mitigate that. It can worsen sleep apnea, but it's not a reason not to consider the device, because you can just change the parameters of the device or more thoroughly treat the underlying sleep apnea, and it could still be an option. Advantages of this device in particular is we have the most long-term data for it, the most experience with it. It is, formally approved all the way down to 4 years of age. There are some evidence that it can indirectly improve other aspects of epilepsy. We heard epilepsy is not just seizures, right? But it could help with mood, cognition, and quality of life from that standpoint as well. And anecdotally, people reporting that it can help with their level of alertness and perhaps shorten the post-ictal state. So again, even if you're not achieving complete seizure freedom, can be a great option. The other advantage is you don't need to know where the seizures are coming from for this. You're stimulating the nerve in the neck. So you might not need to go through as much testing to get to the point of trying to utilize this tool to manage your epilepsy, but you don't want to miss an opportunity for a curative option either, which is why we have that really long pathway that Dr. Hill showed as well. The next device is deep brain stimulation. So this is very similar. The generator is placed on the chest wall, very similar to the VNS, but the leads are fed under the skin, behind the ear, and then into a deep structure of the brain. It's called deep brain stimulation. So that deep structure is the thalamus, and it's usually placed bilaterally, so on either side here. This is what you as the patient might go home with this programmer, and then the tablet that the provider uses in clinic to program the device as well. So where in the brain are we talking about? It's the structure here called the thalamus, and then even more specifically within the thalamus, it's a collection of cells here in the midbrain. It's primary or it's FDA-approved indication specifically for the anterior nucleus of the thalamus. So it's one very specific area in the front of the thalamus. It's approved for adults 18 years old and up. It's more recent, approved in 2018, though it's been used in the neurology sphere for a while for movement disorders like Parkinson's disease, a similar approach or device in the thalamus, but this is a specific indication for epilepsy. It is approved for focal epilepsy, thinking about this ANT location, but again, have been off-label uses and other uses for this device as well. Similar battery life to the VNS, 4 to 7 years, but there's a rechargeable option as well, where you can recharge the battery externally rather than having to go replace a battery once it reaches end of life. So this is going back to this slide here. So far we talked about VNS and DBS is giving continuous stimulation, and the goal is to shift that probability curve down. So they're acting very similar in that way. It's constantly cycling on or off, giving stimulation for 1 minute, off for 5 minutes. Again, this is the kind of traditional use of DBS. There's been other uses over time as well as we learn more about using it for epilepsy. We talked a little bit about where it's located. So the landmark trial that looked at the efficacy of DBS or deep brain stimulation in epilepsy was called the Sante trial. And so here I liked this picture. It's 81 patients. So each bar represents a patient, and then it graphs that particular person's seizures after device placement. And so a few people did have more seizures, but you can see the vast majority of people had some improvement in their seizures. And if you take that, what is it, like the 40th patient, and draw a line right down the middle and say, what did most people experience? Well, the median, the middle, is that they had a 56% seizure reduction after device placement. With any of these, you have to think about at what time point you're measuring the seizure burden. So to break it down in a little bit more detail, 16% of participants had greater than 90% seizure reduction, so if you were kind of maybe super responders in some ways. 13% had a period of seizure freedom. 7.3% had a prolonged period of seizure freedom, but that kind of tapered off after several years. So looking at the 7-year mark, the follow-up study 7 years later, longer-term follow-up for people who have had this device placed, the median total seizure reduction at 7 years was 75%. This can have a side effect of stimulating the ANT specifically. For some people, can actually have a side effect of mood symptoms. So that is perhaps similar to what we talked about with some of the anti-seizure medications and something to be aware of. Risk is higher in those who already had some underlying mood disorder and mood symptoms, but it is a possibility. But overall, was a very safe procedure even at the 7-year follow-up. We do use DBS in the pediatric population, and there is some literature to support it, though it is off-label use. So this was a systematic review of 21 papers that included 40 pediatric patients who had the DBS placed. Again, the ANT, the anterior part of that nucleus that we talked about, that deep brain structure, was the initial kind of primary indication. But in pediatrics, we target a slightly different area of that thalamus, sometimes to try to modulate a different network. And so we think that this CM nucleus perhaps has a broader network that could potentially help with more generalized epilepsies. So that's the idea behind targeting different areas and using the DBS in different clinical situations. Then the third device we wanted to talk about is the responsive nerve stimulation. Again, a lot of similarities with all three of these devices, modulating a network. The first two devices we talked about are doing it all the time in this continuous cycling fashion. You don't necessarily need to know exactly where someone's seizures are coming from, though for the ANT DBS, it's usually targeting temporal lobe epilepsies. But you kind of have this predetermined location of where you're putting the device, either the vagus nerve or the deep brain thalamus structures. It's constantly cycling on and off in the background to modulate those networks. The RNS is a little bit different. It's responsive, is in the name, so it's responding to that individual's seizures. So this is the generator is placed actually right into the skull. So a piece of the skull is removed and a tray kind of takes that place, and then the generator sits flush with the skull. And then the leads are put into the area of the brain we think the seizures are coming from. So this is often something that becomes an option where perhaps you've gone through that whole epilepsy surgery evaluation, you're trying to localize someone's seizures. It turns out you can't remove that tissue, but now you know where the seizures are coming from with some degree of certainty, and it's coming from 1 or 2 locations. Ideally for this device, and then you can more specifically modulate that specific network for that patient and target that patient's epilepsy. So then this is what the actual kind of monitoring device looks like, where the other piece of this is that there is some work on the patient's part, some homework, where it works best if you're constantly uploading the information that the RNS is providing about that person's seizures and epilepsy. So it's actually recording. These electrodes here have tiny little kind of EEG electrodes on them, and they're recording electrical activity in the brain and storing it temporarily in this device. And then you can upload that information, and then your provider can have access to the information that the device is recording. So this is also approved for adults 18 years and up, though again, we have used it off-label in the pediatric population. It kind of is newer as well, but a little bit more recently approved than the DBS. It was approved in 2013. And again, the indication is really for primarily for focal epilepsies, if you can define 1 or 2 spots the seizure is coming from, because you have up to 2 leads that you could place into those networks and modulate those networks. Though again, as we're learning more, we are using it kind of off-label in other capacities and treatment options as well. The main advantage is that information that you're getting. So it's actually recording off of those leads, and then you can look at the data, especially once you tell the device and you tell us when your seizure happens. And then we can look at the EEG information that's collected at that time and know what the seizure looks like from those leads at that time. And then you teach the device to respond at that time. So that's the responsive part. And so that's a different kind of strategy than the other 2 devices that we talked about. So it's giving a stimulation only when you tell it to or program it to. The idea is that it's responding to seizures, but in reality, it's responding to any abnormal discharges that look reminiscent of a seizure. So it often goes off hundreds of times a day. That person's not having hundreds of seizures a day, but it's recognizing some abnormal blips and patterns that you told it to recognize, and then it delivers a stimulation. And so since it's only delivering stimulation when you tell it to, it's not on for 1 minute, off for 5 minutes all the time. It's only delivering a quick stimulation over a few seconds when it recognizes that pattern. That's in part why the battery life lasts longer, up to 10 to 11 years, because it's just working in a very different way and stimulating in a very different manner. But the idea is the same for all of them, to modulate that network and change the abnormal electrical activity and quiet it down to reduce the probability of seizures. This is what it looks like. So from those 2 electrodes placed in a specific area of the brain, we're actually recording EEG data from those electrodes that we can see on our computer. Once you download the data, we can go to the cloud and take a look at it. And so it's recognizing these spiky looking waves here, because we told it to. We said that could be the start of someone's seizures. And so it recognizes that and delivers a therapy, a treatment. And then the efficacy in general is fairly similar across the devices if you're using very broad strokes. And so at 1 year, 44% median seizure reduction. 2 years, 53% median seizure reduction. And at 9 years, 75% median seizure reduction. And I kind of saved this idea for the end on purpose, but I think because it's a different strategy and it's a different tool, the other kind of unique thing about it is that you're not doing a surgery, coming out of the surgery seizure-free, and seeing how long that seizure freedom can last for, and hopefully it's forever, but for some people, seizures eventually come back. This is a totally different paradigm shift, is you plant the device, and then you don't even turn it on. So you leave the OR, and we haven't actually done anything to treat your epilepsy or your seizures. But the cool thing is that it improves over time. And none of our other therapies do that, right? It's not like the medications improve over time, like once you reach the optimal dose for you. The surgery doesn't necessarily improve over time, but these devices can modulate this network over time. And so if you're patient, the long-term benefits can be extremely helpful, but it's a long road to get there. And especially with RNS too, because you're actually learning from each visit about that person's specific epilepsy, that person's specific network, responding to it, and then waiting a few months to see how much did that improve. And then you make another adjustment, and then you wait a few months, and then you see these trends over time that with having the stimulation going on in the background, even stimulating out here in the vagus nerve and just having going on and off in the background kind of all the time, that you can have this cumulative benefit over years. So I think I covered most of that. For, I guess, unique side effects of this, just to kind of touch on each device, it really depends on where you're placing the stimulation for this one, so it's a little trickier. So you have the risk of infection, risk of bleeding, device management, but the actual potential side effects of the stimulation depends on what you're stimulating. So if you're stimulating the motor area of the brain and you turn that stimulation up too high, well, you might get some extra twitches, and we know we need to turn it back down. But we can assess that in real time and control for that. Similarly, like some tingling or paresthesias, if you turn the stimulation up too high too quickly and to get some tingling, then you can turn it back down. So some of it depends on where you're actually implanting the leads. There is kind of looking to next steps in the realm of neuromodulation. We kind of touched on this a little bit already, and that there's some evidence and some experience to suggest that we might be able to modulate even broader, bigger networks to target more generalized epilepsies, that maybe we can even target more than 2 specific foci, maybe up to 3 or 4 specific foci for somebody. Studying other areas of that thalamus that I talked about, because that's really a relay center of the brain for a lot of these networks. And so if the idea is to interrupt a network as part of someone's seizures, that can be an area to look at more and more. This got cut off. But the point of this was just to show that when you talk about efficacy, again, it depends on what study you're looking at, what patient population you're talking about. So in general, I feel like efficacy can be fairly similar, but there are some ranges reported. And then practical considerations, as you're considering, is the device right for me and which device might be right for me? Sometimes it's just thinking about where is the device going to be placed? What's the recovery going to look like? How often do I have to change the battery? With the RNS, I'm supposed to be uploading the data every day, and just some practical considerations. I do want to briefly touch on dietary therapies. It's another huge topic, but ketogenic diet in particular has been used for epilepsy for a long time. But we have other therapies as well that are kind of versions of that, modified Atkins, modified keto, low glycemic index treatments have been used, or MCT. Diets have been trialed. So it's a very, very high fat and even low protein, which I think is something I didn't fully appreciate when I first started, and a very low sugar diet. And so why don't we do this for everybody? Because that's not actually good nutrition, right? Especially for growing kids. And so it has to be done very, very carefully, very, very thoughtfully. And the idea of using diet to control a chronic condition like epilepsy is so appealing. Like using food as medicine is so appealing. But it's actually very not normal what we're doing to the brain with the ketogenic diet. The way it works is by inverting the metabolism of the brain. And so I think it's a wonderful option and a wonderful tool, and I've seen it help a lot of people, and it's definitely something that needs to be part of the discussion when someone has medically refractory epilepsy. But it has to be also used thoughtfully, and there are side effects as well. So here's what I mean when I say a high-fat, lower protein, and very low sugar diet. There are a couple indications where it's first-line treatment, though, which I always found this very fascinating because GLUT1 deficiency syndrome, that's a syndrome where sugar can't get into the brain as well. And so how do you bypass that? Well, the brain doesn't rely on sugar any more than it relies on fat. So that's really cool, and that's the idea behind it. So there are a couple times where it could be the first-line treatment for those very specific indications. We might consider it early on in syndromes that we know are unlikely to be fully treated with medications alone, then we'd want to consider it early on. So things like myoclonic atonic epilepsy, which can traditionally, for some people, be quite refractory to medications, Dravet syndrome, Fires is a specific epilepsy secondary to a febrile infection where the hypothesis there is that it's the inflammation, the acute inflammation, has contributed to the seizures, and there's some thought that the ketogenic diet is acting on that inflammation. And then infantile spasms as well. If they're refractory to our first-line treatments for infantile spasms, then want to get started on the diet early. Efficacy is I often think of it as another medication option, perhaps a really good medication option, but it works for some people, doesn't work for other people, has side effects for some people, and other people tolerate it really well. The other tricky thing about the diet is if it does work well, then long term, what do you do? Because it's not good to be on a super high-fat, low-protein, low-sugar diet long-term. You have to look at things like lipids and heart disease and bone health. And so that's just another factor to consider when you're weighing your options for dietary therapies. But it can be an extremely effective tool when medications alone hasn't helped to calm down that seizure burden. And then if it works, maybe you do it for a few years and then you would wean off of it, kind of like you would consider for other medications as well. I guess I'll pause there.
So we might have -1 minute, is that right? Okay, in 1 minute, I'm just going to go through a couple things. These have been touched on, but I just want to reiterate them, which is sort of the other things, the less invasive things that we should be thinking about, and a lot of them are well covered in the prior talk. All these things should be done really in parallel, right? If you have a problem you want to solve, you should be using a multi-pronged approach to solve it every possible way. So I don't want these lifestyle things to be abandoned when we start talking about invasive treatments. I am going to do this in 30 seconds. So these sleep things are critical. There's some side notes here, but improved sleep almost always means improved seizures, and I don't want to lose that when we talk about invasive treatments. Treating stress and mood is also very important. I don't mean to say that being stressed or being depressed is why someone has seizures, not at all. But those things don't make anything better. They don't make diabetes better, they don't make hypertension better. They exacerbate those things, and they also exacerbate seizures. So treating those things is really important. Exercise does not improve seizures in our literature, but it does improve quality of life and mood. And then being attentive about triggers is really important and can be highly individualized and highly effective. And there we go. I believe that was a question about EpiMonitor, the seizure detection watch. Oh, EpiMinder? Okay, so this is a moment where we would love for you to teach us. Do we have a microphone to share? So we're not familiar with it, and we would love to become familiar with it. Would you be comfortable telling us about it for a minute or so? Okay.
But just real briefly, just because we also want to get.
Okay, an Epiminder is like a hearing aid. It goes up over the ear if you thought you were seeing a hearing aid. And then it goes down the back, and then it goes up into the back side of the head. So far, as far as I know, the only country that has approved this is Australia. It has been approved just recently by the FDA, and I got this message from my neurologist.
Thank you so much. So you know more about that than I do, but I wanted to just introduce the broader topic, which is a really important one. So in this new era, we now have a plethora of devices that have been developed that are implantable devices meant for the long term to record EEG activity and to understand in real life, in real time, if people are having seizures. This is one such device which has been started in Australia and I think is starting in clinical trials in the United States. That could hugely transform the way we diagnose and treat epilepsy. Thank you so much for bringing that up.
That's great. Thank you. Dr. Chloe Hill, Dr. Kerri Neville, thank you so much for the energetic and informative presentation. The Q&A has already started, so I appreciate that. We have about 10 minutes for question and answer, so we have some microphones roving around here. Do we have a first question? We have one up front here. Microphone is on its way.
And while that's coming, I'll just add real quick. Briefly looking up, it looks like that is perhaps more seizure detection, which I also think is an important distinction. So it's diagnostic tool, and that's probably why another reason we didn't bring it up in our talk today, because the devices I talked about were therapy tools. So there are a lot of ways that we can improve our detection and understanding of someone's seizure, but you want to understand the difference between a diagnostic tool and a therapy tool.
Regarding the RNS, so you use the verbiage that it can be trained in a way, right, the device. So can the pattern like change and you can retrain it basically? When making the adjustments, you kind of retrain it? Is that what it is? And can you put two devices, not one? If you know a couple of spots, but there's that third one that you're maybe a little, is that a possibility?
That's a great question.
Reasonable?
That's a great question. So the information you're recording, you're recording electrical activity only from that area is another thing to keep in mind, right? So you have a couple electrodes that are covering like several millimeters of brain tissue. And so you're recording the electrical information from that person's brain from that area. And so it's not usually so much that the person's EEG is changing and dramatically, but that you're getting better at detecting it. Like you're recognizing the patterns over time. So the more data that's uploaded, and you can look at more of the seizures that they're having and then the patterns between seizures and then dial down into what are the important patterns to be stimulating on. That's how it kind of changes over time. And I think that is one of the goals, is to be able to stimulate perhaps even more than two spots. For some people, potentially, yeah.
Good question. We have one more in the front here.
For the ketogenic diet as a therapy, is it also helpful? Do you have to eat ketosis, or is a lower sugar diet also helpful?
Yeah, that is also very patient dependent, I think, too. In my experience, traditionally, when we start the diet, we will set a ketone goal, perhaps of 4 to 6. And some people are able to achieve that and do really well. Some people aren't able to get that high, but their seizures improve. And so then we kind of change our goal based on that person and that person's response and tolerance. And then that's where the modified Atkins diet and the modified keto comes in, is that your goals might be lower and your ratio might be lower, but you could still have benefit.
I would agree with that, and I think it's an excellent question. In the adult population, for whom it's harder to control what people eat, and for whom cardiovascular disease risk becomes a more significant consideration, will often turn to these modified diets, and some people experience great benefit with that.
We've
Good
got
question.
a question over here. Sorry.
Great.
Do you see ablation surgery reducing resection surgery?
That's a very good question. I'm not going to quote numbers to you because I don't have those in my head, but I'll quote what I know. I'll tell you what I know about it. So in our data to date, we do think that resective seizures are slightly more effective resective procedures are slightly more effective at treating seizures, at people achieving seizure freedom, than the ablative seizures to date. Sometimes perhaps the neurocognitive outcomes can be slightly improved in an ablative seizure than a resective seizure, because obviously less tissues involved in the surgery. So oftentimes we will first do an ablative surgery, and that can be sufficient, and that's fantastic. If unfortunately that's not enough, then we can come back and do the resective surgery. So it's very nice in that it doesn't take it off the table, and it's a much less dramatic and traumatic surgery for a person to have. I will say I think what's fantastic about our field is there's a lot of developed right now in neurosurgical approaches for treating epilepsy, and it may be very well true that in a couple years we've shifted to less invasive procedures such as ablation if we have ways to get better efficacy with that.
Great. I think we have time for just one more. We've got one over here in the front right.
And I interviewed with them, and it basically shows the RNS device. It's a whole summary. I had a nice 3-hour interview for 3 minutes on Fox 2.
Great.
So it's something to look into. But they also removed 3 parts of my brain. And I was awake during the surgery, and they were talking to me. I had my neocortex, the amygdala, and the hippocampus on the left side of my brain removed. So otherwise I won't be able to talk to you guys like this.
Wow.
But I used to have 8 to 10 seizures a day, working full time, stress, anxiety, all that fun stuff. And changed it, of course, on and off. And all this was done back in 2011. I had an SEEG in 2010.
Wow.
So
That's
a
incredible.
lot of work that you guys do, surgery-wise, but I've improved 90%.
That's wonderful.
All right. Thank you for sharing that. That is the end of this session. Thank you, Dr. Chloe Hill and Dr. Kerri Neville. We really appreciate it.
Thank you so much for having us. Thanks.